The opinions and statements made by the guests of the Success in Practice podcast are their own, and I do not endorse or accept responsibility for their positions. Any information given by myself or the guests is educational in intention and not to be taken as medical advice. If you choose to act on the content involved in the podcast, you do so at your own risk. Okay, everyone, welcome back to another episode of the Success in Practice podcast. Today, I'm joined by Dr. Lisa DeStefano, all the way from Michigan in the United States of America. Dr. DeStefano is a board-certified in family medicine and neuromusculoskeletal and osteopathic manipulative medicine. Her practice was in East Lansing, Michigan. She is now since retired since 2024. She is a professor in the Department of Osteopathic Manipulative Medicine in the College of Osteopathic Medicine at Michigan State University. She teaches in many of the MSU Manual Medicine series and in the MSU Osteopathic Neuromusculoskeletal Medicine residency program, where she impacts many students and helps them make connections with the neuromusculoskeletal system and how to apply osteopathic manipulative therapy to get great outcomes. She's the author of the classic Greenman book, Principles of Manual Medicine. That's a textbook that's still on my shelves, and she used that as a course guide for the Manual Medicine series at MSU, and it's currently in its sixth edition, I think, if I'm not mistaken. But that's a fantastic book. That's I think sitting on the shelves of many osteopaths here in Australia and probably all over the world. In saying that, Lisa, welcome to the podcast. We're very privileged to have you on here. Thank you for taking the time. I know it's early over there in Michigan. It's late here, and so thank you.
Yeah, glad to be here. Thanks so much for inviting me.
It's probably very cold over there now. I won't rub it in, but it's very warm over here. It's about 32 degrees today. It's a beautiful Sydney summer's day.
It's negative something. In Fahrenheit, it's about 10 degrees. It's very cold here.
Right. Well, I won't rub it in, but
very cold.
Let's get started because I think the listeners really want to get to know what you're all about and get a little insight into your knowledge base. Now, before I do that, before we talk osteopathy, I want to know a little bit about you. I want to know a lot about you, and the listeners want to know a lot about you. Tell us a bit about your backstory and your history, growing up in the States, and how you developed as a young lady, your education background, what got you into osteopathy. Give us some backstory on you as a person growing up.
Yeah, well, I'm from Michigan, born in Detroit, and then my family did a little stint in Ohio. My dad worked for General Electric, and then we moved up to the Upper Peninsula of Michigan, which is above the Mackinac Bridge, the part of Michigan that's connected to Wisconsin. And I pretty much had a pretty free life as a child. I was a tomboy. I hung out with all my brother's friends. We did a lot of bicycling, and we had forts, and we climbed trees, and got into all kinds of mischief as children. And one of those episodes caused me to injure my back. I was climbing a tree, and it was a dead tree, and I think it was March. It was around Easter, March, April. It was around Easter time, and my brother was shooting a BB gun, and he shot the BB gun, and it ricocheted off me, and I kind of jerked, and then the tree branch broke. So I fell about 15 feet and fractured a portion of my spine, just the transverse process of my spine. And it was quite an adventure because there was no hospitals or anything. So we had to go about 2 hours from my home in order to get care. And it was a silly injury. It was something that today would probably put a clamshell around it and just brace it. But then they put a body cast on it.
Yeah.
pass from here to here. It was a little porthole in the middle, and the only way I could really get to scratch my back, which was horribly itchy with the cast on, was my brother and his friend shooting the BB gun at me and ricocheting off the cast. So my mother insisted as I grew up that I see a chiropractor. And this guy was really interesting. His name was Dr. Benson. And he really cared about things like what I ate and how that impacted my spine. And of course, I was a teenager and a young adolescent, an adolescent back then. And I really didn't care about much of those kinds of things. So that was my first exposure to manipulative medicine as a kid. And it was kind of cool, but I loved the function of things. So growing up, I spent a lot of time pulling things apart and then putting them back together again. Toasters. I had an old VW bug, Volkswagen bug that me and JC Whitney were really good friends because I would order parts and then pull everything apart and try to put the parts back in. So when I was in high school, I took chemistry classes and I really loved chemistry. I loved science. So not knowing what I was going to do after high school, I knew I was going to go to college. So I spent my first years of college up in Escanaba, which was the city I lived in. It was a little community college there. And I ended up staying there for about 3 years and getting 2 associate's degrees because I really didn't know what I wanted to do. And I was really young, and my father wasn't going to send me to college if I didn't know what the heck I was going to do. So I finally, at that time, I was tutoring a lot of nurses, older, nurses that were parents and their kids were grown up and they wanted to go back to school. And so I was tutoring in chemistry and physiology and biology. And I really had they were my cheerleaders. They wanted me to move on and go on with my life. And so I thought about becoming a chemical engineer because I love chemistry so much. So I got accepted to Michigan Tech University, which is north about 6 miles, and Michigan State University, which was about south, about six hours north and 6 hours south. So for whatever reason, I chose to go to Michigan State, and it was in 1985. 1985. I was 21. None of my friends were going to college. So I went alone and I lived in the dorms. So I could buy beer for everyone, and I was really everybody's best friend then. But I took studying pretty seriously because there's really no distractions for me. So I quickly failed being a chemical engineer because I couldn't really do the math. Science was my baby and math was my nemesis. So I was in a little bit of a quandary. So I don't know who I was talking to when I was talking to them, but I was thinking about nutrition or maybe medical technology, something in that health field, but I never considered being a physician. I never wanted to be an MD. Just loved chemistry. So, and biochemistry. By then I was doing a lot of more physiology, and I really love physiology and things function, especially in the human. And so somewhere along the line, someone said, there's this osteopathic medical school on campus. You should check it out. And so I did. And I found myself in the Dean of Administration's office, like within that week, laying out my transcript saying, okay, here I am. This is who I am. What do I need to do to get into this college? She was very kind. She laughed. She said, well, you just take a couple more biology courses and apply. I took my MCATs and applied, and I got in at Michigan State. This was by the time I got in, it was 1988. So I graduated in 1993, and I started at Michigan State. I was very fortunate. I did my internship at a local osteopathic hospital. There's none of those left in America for the most part now. But there was then in 1993, 1994. And then I had to make the decision if I wanted to do, what I wanted to do. So I ended up, there was this new residency program. Um, Family medicine was always around, but the osteopathic manipulative medicine component was a residency, which was a full license residency, just like OBGYN or neurology or anything else. But it was only for DOs. The MDs couldn't do it because they didn't have the manual background we got in medical school, what little we got in medical school. So I did both. I decided to combine my residencies. So it was a 4-year residency. And the first year residency was an internship, which was just basic medicine. And then the second year in 1994, I did my osteopathic manipulative component of my residency in family medicine at Michigan State. So I started as faculty in 1994, Michigan State University, and I was fortunate enough to have a lot of fabulous people around me that I could learn from. So I started teaching in our CME program at that time as well. So I grew up essentially in the world of manipulative medicine. I never did family medicine. I still am boarded in family medicine. I still maintain my licensure, but I've never really practiced it.
Let me ask you about you mentioned about the osteopathic hospitals that were around back in those days, and you said that they know, I think that there's no more of those around in the States. Tell us about that. Tell us about I mean, we don't have that in Australia here, so tell us about the osteopathic hospital. What's that all about? What does it entail, and why is it different to just a normal hospital?
That's an interesting story. So back in the World War time, I want to say the Second World War, any of the world wars, osteopathic physicians could not practice in military. Only MDs could practice in the military. So during this wartime, all the MDs went to war in America. Many of them went to war. So the hospitals were emptied of their clinicians. And still in those days, osteopathic physicians couldn't practice in the MD hospital. So when the MDs left, they left their communities. All that was left were DOs because they couldn't fight in the war. And so, but they
So
couldn't practice.
they couldn't they could fight, but they couldn't practice.
They couldn't practice in the war.
Right.
Correct. They could go to war, but they couldn't practice. They couldn't go and be a medic or be a part of the medical field. So they just had to build their own hospitals. So all over America, they built osteopathic hospitals, and it really grew the profession at the same time because all the osteopathic schools were still open and still available. Where a lot of the men went to those colleges and then stayed in their communities. So osteopathic hospitals grew rapidly. And then of course, in the 1990s, 1980s, 1990s, 2000s, they were all absorbed
So
into the allopathic world.
So what was the difference between an osteopathic hospital versus a regular
It was
hospital? Say, yeah,
same
right,
thing. It's just that they were DO hospitals because they had to be need.
right. Was there manipulative medicine practice in those hospitals?
Sure.
Was
Yep.
that, yeah,
Every one of them had an inpatient service where hands-on was utilized, and we still to this day
right.
have an inpatient service that hands-on
And
is utilized.
so the osteopathic hospitals have been absorbed into regular hospitals. And are do they get along? Like, do the osteopathic
Oh yeah,
hospitals yeah, right. So they work hand in hand very collaboratively.
yeah, yeah. You really can't see the difference much anymore between a DO and an MD, and in the practice of medicine, there's very few that use their manipulative medicine skills that they learned in
Right.
osteopathic hospital. Many of them are MD boarded. So they
Okay.
DO after their name, but all of their
So
board certifications were done through the pathways.
is it DO by name only?
So essentially, yep, yep.
Yeah.
They The DO schools and the MD schools are very different. Still, we at least they try to be. They would say that um, DO is a fully licensed form of medicine, and they're very much akin to what the MDs are.
Mm,
They're very proud of their DO name, but they don't
mm,
practice holistically. They may think holistically, and they would just. In America, you really can't. You pretty much, if you're going to go into a specialty, there's standards of practice that aren't very osteopathic. So that's what they're led. That's the path they're led towards, unless they back out of it
yeah,
and
yeah,
choose to go in another direction. And if they do that, they're bucking against the system quite significantly, because
okay.
the two schools are quite different. The MD schools is basically to teach you a disease model. So here's
Hmm.
disease. These are the things you can do to fix it. Where the DO school is still here's normal function. So let's look at normal function, and then when you see disease, it's really okay. Where is normal function gone awry? So here's the alteration to normal function, and that equals disease. So it's really still a very different philosophy in the medical schools.
Okay. Let me take you back to your education as a I guess a 20-something-year-old student. When was it that I mean, you would have, you said that you went to the dean's office and here's my paperwork, I'm in, let's do it. So you went and you started studying osteopathy, I'm assuming. What At what point did you look at what you were learning and say, "Wow, I'm all in. This is." At what point were you hooked? At what point did that, like, was there a point in your education or in your career where that really you just said, "This is amazing. I'm hooked. I can. This is makes total sense to me."
Um, I was probably in my residency by then. I still was pretty much, I loved everything about medicine. Once I got into it, I thought about being an emergency medicine physician.
Mm,
I loved the human body and how it all worked together, and disease, and the big challenges there was to trying to figure out why people were not feeling well. Um, so I still wasn't certain I was going to, if I was going to do family medicine or if I was just going to do the manipulative medicine component. Um, and then, but then at that time, I also was entrenched in doing cranial work, even as a medical student. My first and second year of medical school, I was introduced to, at church of all places, to John Vredevo. John Vredevo was the co-author of Upledger's craniosacral therapy. So Upledger was faculty at Michigan State University, left to go to the Upledger Institute in the late 80s. So this was in the 90s, and Upledger and Vredevo had lost communication. They'd lost touch with each other. And John Vredevo wanted me to get to know Upledger and just kind of see what this world of cranial was all about. So I spent quite a bit of time learning cranial before I learned much of any other manipulative medicine. And I fell in love with cranial and the practice of cranial sacral therapy or cranial osteopathy early on. And but I couldn't use that practice much at all when I was going through my family medicine residency. But I still did quite a bit of manipulation. Once people figured out that I did a lot of manipulation, or I like to do manipulation in my residency, I tell you, Sammy, that's all I did. That's all they let me do, because
mm,
my patients were, I was booked in my residency. From the minute I walked into the clinic, there was no holes in my schedule because everybody wanted me to do some manipulation. So I never really felt comfortable doing family medicine. I never felt comfortable treating a diabetic child, or really thinking through complex metabolic syndrome, because I spent all my time not doing that.
yeah.
So at the end, it was pretty much, I was all in by the time I was done with my residency. I felt like there was a big role for me but that I had a lot to learn.
Mm.
It was probably
Yeah.
the time somewhere in my residency.
And who were your influences in terms of osteopathic philosophy and manipulative medicine? Like, tell us about who are some of the key people that influenced you in how you think, more so in what you do, but also in the techniques that you learn.
Well, certainly all of the above would be Phil Greenman.
Yeah, right.
Um, he wasn't my program director early on. Bob Ward was. Bob Ward was an osteopathic physician. Father was a DO. And Bob loved manipulative medicine, but only fascial work and only Bob Ward fascial work. And it was the integrative neuromuscular release that I teach now. It was good work. It was fabulous stuff. But he did not like the structural aspect. He
Right.
was very direct, but he didn't like structure. He didn't like biomechanics. In fact, anytime you talk to him about joint facets, he would lose his mind. That
So,
joint, you know.
so
So
was he just looking at fascial trains? You
yes,
know,
he was looking.
fascial trains and
He was not looking at kinetic chains. He was just looking at Ward getting his hands on people, doing his thing, and
right.
talking through the mechanics, but not really in a way that was very physiological.
Hmm.
But that was Bob Ward. He got good work done. His patients loved him, but he really couldn't make sense of the world for me
Right.
from an intellectual perspective. And he wouldn't let me work with Phil Greenman until my second year residency. And when I did, it was quite the event because Phil Greenman worked. He was at Michigan State, but he worked in the PM&R group. He didn't work in biomechanics in the OMM group. So because he was treating a lot of head injury patients, he was treating a lot of jaw pain, more traumatic accident kind of patients. So they were a little bit more complex. And so I went over there for the first week of my rotation. We just saw everything he did, Phil did. I knew what he was doing. Oh, you're treating a joint in this ERS pattern or FRS pattern. I could
Mm.
see, everything I had learned, the basics, he was actually doing, and it made sense why he was treating what, and then he was adding the story to it and why it was important to treat the pelvis in this sequence. You treat the pubis first, then lumbar spine before you treat the sacrum, and so at the end of the week, I remember we were sitting back in a little corner of this office, and I was sitting, and he came in. He said, "So, Lisa, do you have any questions for me?" It was Friday afternoon, and I looked at him, and I just started crying. I mean, and he's like, "Oh," and the reason why it was so emotional is because it finally clicked. I mean, someone
Yeah.
could talk to me in a way that was just so beautiful, and it was everything I hoped and dreamed. And so from that moment on, I never left his side. Everywhere he taught, I was there.
Yeah, that's amazing because it feels like I'm talking to you, but it feels like I'm in a time capsule because, I mean, I was studying in the late 90s, early 2000s, and that green book, I mean, it's Greenman, but it was a green book, and it was just there all the time. We always look back at it. I still remember those square pictures with him in his white robe, um, doing the demonstrations and the wording underneath it. It's just an amazing book. Like it's phenomenal now that I'm talking to you and you were there with him. It's just yeah, it's a bit surreal, but it's great to have that link because as you start to practice and you start doing those things that you do and you get the results and things become second nature, it's always good to go back and understand that that what you're thinking and what you're doing now, other people before you have come and they've also thought about it and they've done it and you're building upon that. So that blows my mind and it's really amazing for me. So yeah, that must be a great experience for you to continue what he's doing. I will ask you about that in a later question, but that's just, yeah, that's amazing. I guess I want to fast forward then to your practice. So after finishing your residency, you then moved into private practice. Did you work with was Greenman somebody? Was he a practitioner? He was somebody that was actually seeing patients and at that time still practicing, as an osteopath.
Yep, he was. He was in the physical medicine rehab. He retired shortly after I got into practice.
Right,
Of course, I stayed at Michigan State University, and we started out um, in the hospital, and he was not part of that practice. That was kind of an extension of my residency practice.
right.
So I was probably the first of the residency. I was the third person to go through the residency.
Mm.
And now we've graduated many, many more since then. But I was the third person, so I was the first to stay with the program.
Yeah. And tell us about what normally happens. Do you stay at the hospital? Do you work in a hospital? Do you go into private
Yeah,
practice where you see private patients? How do things work? How do they
it
work with
was
you?
so it was an extension of Michigan State University. So I was a faculty member there throughout, and
Right,
so I was getting paid to see patients. My money from patient care came back through the university,
right,
because I was also getting paid to teach medical students. So I did both of those from 1997, when I graduated from my residency, until about 2011, 12, something like that,
right, right,
where I had 20% of my, or 30% of my time was just teaching students, and the other 70% was inpatient care. So,
right.
and we were seeing patients.
And tell us about your volume in terms of, say, on a busy day for you in terms of seeing patients. What kind of volume of patients are you getting through? Is it
we
like
were
you
seeing
have?
we were seeing patients. I was probably seeing 25 to 30 patients a day. If it was a
Mm,
full day, half day was 12, 13.
right.
Yeah.
And most of your, I guess it was 90, or was it mostly hands-on, manipulative,
Yep.
all of it
Hands on
became that
the
way.
whole
So
time.
you never went down to any kind of looking at metabolic issues or kind of internal medicine, anything like that. That never really
Nope.
crossed your mind. Right.
No, I
Okay.
thought about it. I listened. I advised my patients who came in with
Yeah.
stories of health issues, and
Yeah.
um, I integrated a little bit, but most of it was just helping them kind of figure out that maybe they should consider a diet pathway, or
Right.
non-medicine pathway.
Okay, so your time at the university was your education time at the university was spent teaching osteopathic students how to be osteopaths largely. So tell us about that. Like, tell us about your journey in education and what did you teach and what are you teaching now?
Hello, everyone. I'd like to take a quick moment to thank everyone for watching and listening to the podcast. If you have received value from this episode, the kindest thing you can do for me is to like, share, follow, and subscribe to the channel on whichever platform that you are listening on. If any of the conversations have resonated with you and you feel that I can help elevate your practice, you can find me at successinpractice.net. That is, the Success in Practice program can be found at successinpractice.net. The Success in Practice program is the signature program that takes a practitioner who may be struggling with retaining patients. They may not be certain about building effective treatment strategies, and they may feel somewhat anxious and doubtful about what they are going to do with a patient. And they are not really accelerating in the real world of private practice. It takes this practitioner and it turns their careers right around to the point where the patients have an effective diagnosis and a real treatment plan that they can take home. Patients are happy to book in multiple sessions with you and they are confident about your abilities. And more importantly, you now have direction and are confident about your own abilities. The program streamlines how you operate as a practitioner. Guys, you should have been taught this at university, but you weren't. You may have been practicing for the last few years thinking there has to be a better way. There has to be a more effective way of engaging with patients and getting them results. Well, there is. And this is what the program delivers. Go to successinpractice.net and check out the options available to you. See where I can help you easily grow your patient list and finally earn the rewarding income that you deserve. For all the information on how you can reach me personally, check out the show notes. Also, in the show notes, you'll find a link to the chat transcripts from these podcasts. These are valuable and a wealth of information. I really hope that you're enjoying the podcast. Guys, leave a comment if there's any questions on this episode. And please don't forget to like, share, follow, and subscribe to the channel. Now, back to the show.
So my journey in education started in 1994 when my second year in residency, I actually started teaching within the MSU Manual Medicine series with Phil. At that time, the Manual Medicine series at Michigan State, which is the Greenman's Principles of Manual Medicine, actually the course. That series started in the 70s with Phil Greenman, Paul Kimberly, John Minnell, John Bordillon, and Myron Beale. And their job, they really just wanted to teach the teachers. And they were part of the North American Manual Medicine group that blended with the Federation of International Manual Medicine. So by the time I reached that group, by 1994, there were other instructors. John Burnell and Badilla, of course, had passed. So I grew up basically teaching, even from a young age. So I loved medical education. When I was teaching the medical students, I was very dissatisfied with the stuff that we could teach because it never made sense to me to teach a first and second year medical student something that they could never apply. So teaching a technique, it became just like, okay, I'm going to mimic what you're doing and then pass the class. It really made no sense to them because there wasn't time to really, we had maybe 150 hours of manual medicine training throughout medical school. You think about that difference between your 7,000 hours or, it was really quite different. So I started at that time a student clinic, so allowing the students to actually practice on other people. So it was a formal clinic. The students had to figure out their own scheduling and everything like that. So that was part of, educating them. And I did that for a while. And then in 2003, I became the chair of the department. So that caught some of my time. And I did less medical school teaching, student teaching, after I had recruited a lot more faculty, many more faculties could essentially, they could do some of this education, but I never really got out of patient care. I wanted to see patients 60% of my time because that's where I really felt that I was still learning. But I continued in the manual medicine series, and that series brought in people that asked me to go and teach in other places. That series, plus my being the chair of the department, brought in other professionals from other countries like Japan and Korea. So, and they teach, they practice a little differently, but manual medicine is a big component of what they learn. So they saw Michigan State as the mecca because of the manual medicine series. So that series afforded me a great deal of opportunities to teach. And it also afforded me the opportunity to edit the fourth, fifth, and sixth editions of Principles of Manual Medicine. So
Yeah. Okay. What I want to ask you is, you mentioned you touched on this earlier. You're teaching basically students who want to be osteopaths, but yet have to also understand the internal medicine disease model as MDs, but yet you're teaching also the DO component of it. How do you reconcile those two models so that the student experience isn't as challenging as I guess it probably would be, given they are not always in line with each other.
Yeah, I talk about function.
Yeah. Right.
More than anything. I just, if you have a cardiorespiratory problem like COPD or asthma, you have to know a lot about the medications.
Mm.
Medicine is just about the medication. So do you use a steroidal inhaler, or do you use a non-steroidal inhaler? I mean, there's all these new drugs. So yeah, so that's what they learn primarily. But so we just talk about the rib cage, right, and the
Right.
diaphragm and the excursion
Yeah.
of the diaphragm and the thoracic spine as it relates to the excursion of the diaphragm. I reconcile it that way, and I just make them understand that you can't have one without the other.
Mm.
So
Right. And
that's the only
so
way you can.
I guess with that model being, I guess, more evidence-based, right? Like when you look at the
Sure.
pharmaco kind of medical model, when you then go and try and teach some of the principles that, for example, we see in principles of manual medicine, flex, side bent, rotated, nutated sacrum, backwards, forward sacral torsions, all these things that we love about Greenman's principles of manual medicine. And then do you get the kickback of, where's the evidence for this? How do you know that you're actually feeling this? What evidence do you have that this is actually happening? What are your answers to these? Especially as an educator? I mean, you're somebody who's in charge of the education of osteopaths at a university, and those questions will be something you'd have to tackle all the
Sure.
time. How do you do it?
I bring it into function again. So, what literature is there that talks about the gait cycle? There's a ton of literature there about the gait cycle. Nutation and counter-nutation is not an osteopathic term. It's actually a term that was defined by physiologists back in the 40s and 50s. So we remind people that y'all walk, y'all have you're all bipeds. So
Yeah.
and the nominates do this while you walk. Pubic symphysis does this, but the sacrum is kind of wedged between the two of them. So the sacrum moves, and so might not believe that the sacrum has these particular axes of motion, and that this is the joint is the same on every single person. I get that, and that's fine with me. But the reality is that sacrum had better be able to nutate when you walk. If it can't, then that joint's really not going to function well. So I define it in terms of kinetic chains from the foot on up through the contralateral latissimus dorsi and upper extremity. If you think about that, and you have a joint dysfunction, it's really going to hammer it. It's going to the kinetic chain's broken somewhere. So that's likely why they have their pain when they do. So let's figure that out and let's reconnect that system. So I don't disagree with them necessarily. I just show them the reality that hasn't. It's like, how do we know that ibuprofen works? What's the great science behind acetaminophen? What's the great science behind auscultation of the heart? There's really not that much behind it. So there's really not that much behind physiologic axioms other than that are written in concrete in basics or in evidence based. But there's a ton of it in physiologic based science.
Yeah, I think you're right. I mean, gravity's still acting on human beings, just like anything else in the world. And physics is physics, and mechanics are mechanics, and people have to move, and those movements have to be defined in a certain way. We can't escape that. And so, cars are affected by the laws of physics, and so why aren't humans affected by the laws of physics? So I understand that. I guess it's more the practitioner's particular ability to feel what they believe they are feeling and have that then be able to be reproduced, so that when I look at a textbook like Principles of Manual Medicine and I say, yes, I can feel that, and somebody else can't feel that, excuse me, how do you deal when you get a student that asks you that question? How do you deal with that? What advice do you give them to make sure that they're not disenchanted by, I guess, the inter-rater reliability of what they're trying to do under their hands?
I think more than anything, I give them the principles, palpation. I talk about compliance and non-compliance of tissue, and then I set them free. Sometimes I
Right.
use the example of, palpate the table.
Yeah.
You feel that table. Does it feel alive to you? Does it feel biological to you? Does it feel like it has a system below it that is actually functioning and moving? So we walk through lots of what I call palpatory sense kind of motions or tactics. And then I set them off on their own world to learn exactly how to figure out those mechanics and what they mean. Not everybody will see the sacrum or look at the sacrum from a three-dimensional perspective, but they'll still feel like there's an SI joint dysfunction, and they get there in different ways. And I don't discourage that, because
Right.
for one person's pathway isn't necessarily the same pathway I understand that people are concrete and congruent in the way that their hands and their brain work, and some people are really not concrete. And they feel more comfortable in the fluid perspective and fluid model or indirect model. And there's an importance for that. I'm very direct, very structurally minded, but I also have taught a lot of people that they can't look at something and say that's symmetric or asymmetric. They got to feel it. They have to kind of put it somewhere in their mind. So I give them that room.
Yeah. There's been I know here in Australia, there's been recent debate, and I guess, we kind of tend to critique some of the frameworks that were taught when I was going through, and I'm sure you were taught the same thing. Things like Freud's laws and, understanding movement, spinal movement, just to give an example. How important do you think it is to have a framework, at least a framework in place for a student to be able to start to navigate the movement of the body? I know that, starting out, you're not going to always find an exact type 1, an exact type 2 type of segment or a spinal segment there. And then sometimes things don't make sense, but you really need a framework as a student in the early parts of your career. How important do you think that is, that we continue to give them that framework? Or do you think that we need to open up and just say, look, these laws aren't really anything that we can prove, and so let's just treat what you find?
I think it's very important to look at that framework. I think it's very important to look at facet motion in either a motor unit or a myofascial unit, however they want to define it. But the facet, that structure, Friat's laws, is very important for a first-year student to actually understand flexion and extension. They have to understand the caveats of that, of course, that the cervical spine really doesn't have like one behavior, why that is. So I think it's just how it's taught that can be very confusing to students. That it's either the facet's either engaged or it's not engaged. If it's engaged, is it engaged physiologically or not physiologically? And the reason why that makes a difference is because of the proprioceptors within that joint and how they communicate back to the local stabilizers of the spine and stability. So I've kind of like to blend it with Punjabi's work on stabilization of the spine, which is that's basically how I approach it. So from that point, they can choose to treat that dysfunction any way they want to.
Right.
They can treat it directly, indirectly. It doesn't matter to me how they treat it, as long as they understand that joint dysfunction is causing havoc. And I also give them the concept that a patient's not going to walk in the door with a single segment type 2, and say, "Oh, doc, it's killing me, and there's so much more. There's stacking, there's compressions, there's bilaterals, there's, it's just, you got to try to fit it all together into why it's important to treat that particular joint.
Yeah.
Where does it fit in the role of the patient's pain?
Yeah, I mean that obviously develops as you get more experience, but it's so important to have that framework there as a student, right?
So
like it's because
it's critical.
Because you could get lost. You could easily get lost and just go, "Oh no, this is not for me." Right. Yeah.
And I experienced that with Bob Ward, because he absolutely refused to talk about the joint. He just never really. He thought it was just all a matter of fascial kinetics and how they moved, and loosening everything up is going to work.
Yeah, Freud's laws when you look at them, they tend to be based on obviously the orientation of the facets and how they sit in relation to each other. And you could extrapolate that to the lower limb. You can have a look at how the tibial plateau, sits in line with the femoral plateau, and how that would cause certain movements in the knee, and why the knee is a hinge joint and loves flexion and extension and really hates rotation, and why most dysfunction at the knee happens because of rotation of the tibia. And so that comes back to the orientation of the joint surfaces. And so it's important to understand the reasoning behind Freud's laws, because then you can apply that reasoning to other parts of the body, and you can develop your own understanding of how the body works, how the hip works with the knee, works with the foot, works with the ankle. And so I think, especially here in Australia, I think people or educators are throwing that out at their own peril.
Yeah.
And so, yeah.
The knee is a wonderful example, because if you think about the knee, that research has been done by Cohen and Cohen way back, I think in the 60s, where if the knee has a little bit of effusion, like 20 cc's of normal saline in the knee joint, the capsule of the joint is going to think that it's damaged, and so it'll knock out the VMO, the quadriceps. And we all know that chronic knee disease leads to weakness of the quadriceps, and particularly the stabilizer aspect of the quadriceps. So I use the knee as a really good example. It actually works the same if you have a facet joint that won't open or won't close. It's going to inhibit, because the capsule of the joint sends so much proprioceptive, mechanoreceptive information back to the cord, that it's going to influence the stabilizers around the joint. Yeah,
the facilitation at that level is markedly higher, I think, than the peripherals. I want to get your take on, I guess. Well, first of all, I want to ask about your insight into Australian osteopathy. What is it that you know about Australian osteopathy, and how we do things here? What's your take on that?
Well, it's American osteopathy that's the strange one, right? I mean, osteopathy in the world is full licensure manual medicine, but also integrated with the rest of the organ systems. It's the way osteopathic medicine really should be. I think that American osteopathy is lost its way. I'm very envious of the amount of schooling and education in manual medicine that European and Australian osteopaths have had, and it's also different in the sense that it's not so blended and nicely separated from medicine. I think the challenge, because it's it can be a musculoskeletal focus, but not everybody is focused in the Australian practice of osteopathy on just the musculoskeletal system. There's a lot of people that are focused on pelvic floor, or OBGYN and pediatrics as it relates to the musculoskeletal system and other systems. And I think that's beautiful. There's some subspecialization that is practiced. We see that within our physical therapy practices here in America, that some people, just kind of narrow their scope, even though their scope in education is very broad. So, yeah, that's a beautiful thing.
Yeah. I asked this question to most of my guests, and I'm going to ask you the same question, and I would like to get your take on it. What is osteopathy? To you, what is, like, if you had to define it, what is osteopathy?
I see it as, in a biological system, is the normal function of the body's systems and interrelationships, and all systems, from the integument to the musculoskeletal system to respiratory, circulatory, harmonization and integration of all the systems, which makes us a living, breathing, thinking person.
Right. And a lot of the guests that I talk to will kind of tell me their take on osteopathy, and invariably it comes back to the principles that we get taught anyway. The four principles, the Kirksville principles, as they're known. The body is a unit of body, mind, and spirit. That the body leans towards regulation, maintenance, and healing. That structure and function are interrelated, reciprocally interrelated, and that osteopaths treat based on the rationale of the first three principles. Would that pretty much encompass how you believe osteopathy to be?
Yep.
Yeah.
I agree. And you say it the very last one. You treatment is only as indicated. So yeah, even it's beautifully said.
Yeah, well, that last particular principle, it's when I was a student, I kind of heard it and I thought, well, that's obvious, why would that be there? And it's obviously there to make sure osteopathy is well defined, because it can be a little bit arbitrary. These principles can be little like ideas in the sky, and we want to try to kind of bring them down and try to make them really applicable to the patient in front of you. And I think just having that last principle there really defines what osteopathy is. Osteopathy is a rational application of treatment based on the first three principles. And I think that's a great place to be. And the further we move away from that, I think the further we get a little bit lost. And I think the work you've done with that textbook is right down the track of that philosophy, and I'm happy and I'm so proud to have had that book influence my particular practice. And so I want to ask you now about that. I want to ask you about your experience in, I guess, authorship of that particular book, and that the Principles of Manual Medicine, that was originally authored by Phil Greenman. Tell us about your experience in taking over that authorship. What's it taught you? What were the challenges for you? And how do you see it now as a particular, how does it stand amongst the osteopathic texts?
I was able to take over authorship of that text while Phil was still alive, after he retired. So that was a little intimidating.
I
The
bet.
biggest decision I had to make is if I was going to edit it myself or edit it as a team, much like the Foundations of Osteopathic Medicine.
That's another great book.
So I talked to a couple of my colleagues, and it's very hard to herd cats. So I decided to take it on myself, and then I could always make decisions after that. So again, I try to keep it in line and with the truth about the book, which is the book was never meant for osteopathic medical students. It was
Right.
never meant to be a textbook that was brought into the classroom. So I never worried so much that I was in competition with the foundations of osteopathic medicine. The book itself was always meant to be a course pack that worked together with the Main in Medicine series. And the first thing I saw was that the first challenge was to keep it in line with that, because we were teaching so many more courses and we had so much more expertise in those Main in Medicine courses that the book wasn't keeping up with that expertise and that science and some of the principles that were being taught. So that was a bit of a challenge. Um, the third edition of Principles of Main in Medicine is the one edition that has all of the exercise prescription
Right.
material in it. And I want to say that's the white one. That I learned very quickly that material I could not edit for the fourth edition because it wasn't Phil's to put in the third edition. That work was all done by Mark Bokow. And it discouraged Mark, who's a faculty member within the series. It really discouraged Mark from ever writing his own book on exercise prescription, which is a big piece of the course. So I pulled it out of the fourth edition and tried to not make it real obvious to Phil that he shouldn't have ever put it in a third edition without giving Mark Bokow any credit for the material. So that was a bit of a political issue that I had to deal with right off the bat. I asked Mark, I assumed I had a conversation with Mark Bokow about that, who's a PT, and he's a fabulous physical therapist. He's taught me a lot. He's one of my other great mentors. I asked him at that time, I said, all right, I'll pull it out. But I really expect that you're going to write your own book.
Yeah.
But he never did, and he got sick after that. So it was the sixth edition where I asked Mark Bokow to write with me, co-author the sixth edition with me. And so we could put a lot of his information into what was rightly his as part of, in the fact that he was part of the faculty for so many years at Michigan State University. And he did. Unfortunately, he passed away in March before the book could be completed. So he never had much input into the very last two chapters and the cranial chapter, which I wrote. But it was nice to have his influence in some of it. So that was a challenge. But the book overall has allowed me to really update all of the references so that it still really didn't have many references in the book at all. It was just suggested readings. So referencing our material, his material, the material, was quite a challenge, and it taught me a lot. And then over the fifth edition, sixth edition, we've been blessed to have so much more influence by the fascial conferences and the fascial congresses and the work of Stecco and Schlepp and Schneider's and other Helen Langevin, and really have added quite a bit to what we know about kinetic chains and biomechanics. And so trying to incorporate that material without, taking up so much of the book that it's overwhelming. And then Phil wrote the cranial chapter in a way that really wasn't in keeping with how he taught or how we practice. So some of the chapters rewritten just to make more sense of how we practice rather than how it's taught.
Right.
Because there's clinical application, and then there's practical, and there's practical application, and then there's clinical application. And I'm trying to make it more clinically relevant, the whole textbook, because I think that the book is not meant for a medical student. It's meant for people who are in practice, who are just who already know what they want to do, but that they have big questions about how to go about solving problems for their patients.
Right. Why do you think it was so good as a source for osteopathic students then? If it wasn't written in that way, my memory of it, and I still use it, but my memory of it as a student was that there were really nice pictures in there. There was step-by-step explanations of how he was doing certain techniques. And that really helped as a student to kind of go, okay, step 1, step 2, step 3, step 4, and that just made things a lot easier. So that for me was one of the things that really attracted me to that book. Why do you think, even though it was written for a practitioner, why do you think students have kind of taken this and gone, this is an amazing book?
Well, because it was the first book that really had that step 1, step 2, step 3. There wasn't a lot back then that had those pictures.
Yeah.
Of Jake and Phil doing the work. And I think in part it matched. It was a way for you to take what you learned in the classroom, which was kind of this, okay, what did they just do? To where there were just slides maybe and presentations back then. It wasn't really, foundations of osteopathic medicine didn't have all those pictures. So, but then you could pick up this book and say, oh, this is what they did. So step 1, step 2, step 3 was really there. And then the beauty of it is after you kind of figured out step 1, step 2, step 3, say you were later in your practice, if you went back up above those images and read the text, he defined the biomechanics, why you were doing step 1, step 2, step 3. And then at the end of the book, you have the clinical correlations pieces that were, okay, so if you have low back pain, I know to do step 1, step 2, step 3, but then here's all the other pieces that go together with how to look at the complex problems within the patient.
Yeah, well, it's good to put a name to the model now, Jake. I know it's Jake, so I knew
Jake,
that was
Jake Rowan. Yeah,
Jake Rowan.
He was
Okay.
a faculty of mine. He's still here. He's still at MSU.
He was just in his shorts. That's it. He was just wearing a pair of shorts. Yeah,
his Speedos. We call
it. That's right.
We actually have changed. We have the 6th edition is some colored photos, and it's a female resident of mine, and Jake. So we have a little bit of a mixture, and it's a funny story. I have a wonderful woman physician, Do Terry Steppe, and she teaches for us in our Southwest campus, and she's ADD. She's kind of like OCD, so she would look at the book and she'd be like, "Oh, this is organized wrong," and so she always wanted me to reorganize it. So the 6th edition, I really let her. The 5th and 6th edition, I let her reorganize everything, even the index. She wanted to reorganize. She hated the fact that I was using old and new pictures because she's so, OCD. But it drove her nuts that we were going to do color pictures on top of black and white pictures.
I want to talk to you a little bit more about the exercise prescription part of it, because obviously, I mean, Mark's since passed away, so we can't talk to him. It would have been great to get Mark's book out on the podcast, but in terms of the osteopathic application of exercise, of movement, let's say, we haven't really. I mean, we osteopaths are still. I know here in Australia, I can kind of talk about it, but I want to get your intake because is it the same over in the States? Is there consensus about how we should be teaching the application of exercise and movement within the osteopathic framework? because it's another tool in your toolbox, right? Like exercise isn't medicine. It's not the medicine on its own. It's one of the tools that you use to help people, I guess, build resilience in their tissues. And so, do you think there's consensus on how we should be teaching it? Have we looked at it? Have we gotten together and put our heads together and said, I mean, you've gotten Mark, who's a PT, who I'm assuming the reason why you've used Mark is because he's been close to Phil and he has this kind of integrative approach to the way he prescribes exercise and movement. But there's a real opportunity there for us as osteopaths. We haven't really defined it yet. And I think we're just taking things from physiotherapy and exercise physiology and this, and oh, this looks new, this looks great, let's do that. But we haven't really incorporated it into the osteopathic philosophy. Can you comment on that?
Yeah, there isn't a lot that's being integrated still. There's a lot of misinformation more than anything on the internet as far as what to do as far as exercise for particular things. There's still, bend over and stretch your back, knee to chest kind of activities for low back pain. So I think we're really, really missing the boat. All of what I teach now is about movement and how to integrate movement and how to treat the joint, really to just get that stiffness or that fascial load to get distributed through the system in a more cohesive way. But the reality is the patient still wants to kind of lock down and load into their ligaments and joints when they stand and when they move. And so it becomes a vicious cycle. So if we're really going to help our patients long term, in particular, if we're going to decrease the amount of hip disease and knee disease and shoulder pathology, and decrease the expense of some of these orthopedic surgeries, which are really highly encouraged. You're almost entitled to have these surgeries in America. And that's just, it breaks my heart to see that. We're going the opposite direction. But in order to decrease the incidence of these problems, we have to hold ourselves in space. We have to understand the role of posture and movement. And I'm the only one really talking about it. I think that it's encouraging to hear other people really care about it. I don't know of anyone that's doing it though.
Right.
In
No,
America.
I think it's something that we do need to attack, well, not attack, but we need to really talk about as a profession, because the thing that really gets me a bit riled up is that you take this osteopathic physician who's very holistic in the way they approach things. They connect the dots. They're using principles. They're looking at strain patterns. They're looking at biomechanics. They're treating very holistically. It all looks amazing. And then they get to the part where they want to prescribe an exercise, and then they split the body into 100 different parts. That's not what we do as osteopaths. We don't look at the body as a bicep and a hamstring and a knee and a hip and a foot. We don't. We look at the body as an integrative system, and that system moves in unison in a particular way. And so you can never have, like this whole idea of isolation. Let's isolate the quadricep. It's archaic to me. It doesn't make sense. How are you going to isolate the bicep in a movement? Like the hamstrings are going to get involved, the hip flexors are going to get involved. You have to move the hip, you have to move the knee. So why don't you just squat? Why don't you do something like a squat that's going to integrate that movement into a system of movement that will then increase the strength in the entire chain? And so that's been a bit one of my pet peeves, is that people aren't, when it comes to exercise, we don't have that framework. But then when we're in the clinic, we are really good osteopaths. And so I hope that we can, I guess, talk about it. The more we talk about it, I guess, the more we can come to some kind of understanding. And I would love to see a section in a principles of manual medicine that deals with exercise through the osteopathic lens, not through a PT lens or a lens of, this is what we give for this pain, or this is what we give for that pain. It should be something where we look at the body in a systematic way, how we do as osteopaths. Is that something you'd like to see happen in the future?
Hello, everyone. Just a quick break to give you some information on where to best find me. The first place is the private Facebook group called the Successful Practitioner Pathway. I've set up this private group as a place where practitioners can go and get tips and advice on how to best accelerate their practice and improve their clinical practice skills. The second place to find me is at successinpractice.net. That is where the Success in Practice signature program is housed. You can find more information about me and how I can best help you achieve success in your practice. So, the two best places, the private Facebook group, the Successful Practitioner Pathway, and successinpractice.net. I will link to both those places in the show notes. So, for more information, please see the show notes. Now, enjoy and back to the show.
Yeah, absolutely. So, and I've tried to do a little bit of that in the clinical correlations chapters on the lower quarter and the upper, in
Yeah.
both the 5th edition and then the 6th edition.
Yeah.
Just put it all together and talk about, and it really comes down to stability. That stability isn't just being able to fire glute max. Stability is to be able to integrate function from the foot through the upper extremity.
Yeah.
Yeah, that is something that I'm definitely working on, because we're going backwards. We will go backwards otherwise.
Yeah, definitely.
Our patients will keep coming back to us again and again and again, so it's great for business. But the reality is, until we get them to hold themselves up in space and give them things that would strengthen their core without doing sit-ups, right? Just normal, stiffness that incorporates the transversus just with the everyday movement, we're always going to have pain.
Yeah, we're always going to have pain, and function is, I guess, very specific in what you're doing. Like, it's really hard to get somebody to do a whole bunch of sit-ups on the floor and then expect that particular movement to affect motor patterns while you're standing up and lifting shopping bags out of your car. It just doesn't make sense. Neurophysiologically, that's not possible. So why are we sticking to these guns that don't belong to us? I'm not sure. I'm not really sure why. We could probably do a whole nother podcast on this, Lisa. So I'll discuss that with you at a later time. But tell me a bit about what you're coming at. You'll be out here in February next month.
Yep.
I think we're recording this in January, and I'll air this before you come out. Tell us about what you're planning on teaching when you come out here in February.
So in Australia, we'll be in Melbourne, and I'm going to be teaching a structural cranial course, which is my form of teaching a clinical application of treating the head and the neck, using cranial osteopathy, but it's 2 days and very structural, very simple process that Phil taught me, called walking around the temporal bone, that will be able to really make clinical practice of headaches much easier,
Right.
much simpler. I'll be doing my classic peds lecture, 2-day course on application of osteopathic manipulative medicine on primarily newborns and infants is where my big focus is, because that's where they tend to have their most of their struggles. And then as they get a little older, we might look at the pelvis and the foot and things that are important. But for the most part, it's a way to clinically approach a newborn. And then what else are we doing? We're doing an extremities course for
Right.
occupational health, as well as sports related work. And this is really a myofascial pain course. So this is a course that really looks at function. So someone may come in with fascial pain syndrome like shin splints or hamstring pulls or epicondylitis, right? And it may be occupation related or sports related injury. And it really looks at the function. It looks at joint function, but it also, we're looking at kinetic chains and force distribution and pronation and supination. It's like Friat's laws to all the other joints, right? 6 degrees of freedom. You get one end that's in the supination plane, where the other end is in the pronation plane, depending on what you're doing every second. So, and if you're an overpronator, then the supinators have to work to counteract that. Or how does the musculoskeletal system address that? And why is it that it doesn't address it properly so that you get the overuse syndrome? Where's the joint in all of that? So what joints do you treat and why do you treat them? So it's a whole course about stability that's beyond just the pelvis and the thorax. And then in New Zealand, in Auckland, I'm going to teach another course that's just going to look at the masterclass, looking at the stability of the upper quarter. So from T12 up.
Right.
And that's going to get into some of the movement patterns and exercise and joint and overuse syndromes as well.
Okay. And I guess students can be expected to be very hands-on in those courses. Right.
Yes.
Okay. All right. And I guess I think you're doing that through Manual Medicine International. Is that correct?
Yes. John Marshall's.
John Marshall's. Yeah.
Manual Medicine Australasia.
It used to be Manual Medicine Australasia, but I think he's changed it now to Manual Medicine International. He's a
That's right.
He's getting expanding, John. He's out there.
Yes, he is.
He's taking on the world. I love John. So shout out to John Marshall. Yeah. Right. And I guess one of the last things I want to ask you is, where would you like to see osteopathy go in the next 20 years? How would you like to be, I guess 20 years will probably take you towards the end of your career, when things are winding down a bit more. How would you like to where would you like to see the profession?
Well, I'd like us to really treat the musculoskeletal system as a system we understand. I think it's a system that is not, in particular in America, but even in I think everywhere, osteopathic physicians would be best suited to really understand the normal function of the musculoskeletal system, how everything fits together. I think we get bits and pieces. We know how to treat things. We know how to be great technicians, and we get our patients better. Our outcomes are fabulous. But we still are left with a lot of disease. So I think the mainstream medicine overwhelms us with this concept that as you age, you're going to lose a joint. You're going to destroy your spine. And you expect that you're going to need back surgery, or expect that you're going to have lots of low back pain, and expect that you're going to have a hip replacement or a knee replacement. And I'd like to see osteopathic physicians all across the world kind of buck that thought process and say, no, it doesn't have to work that way. Just because you're 70 doesn't mean that your hip should everywhere out. Your body's not made haphazardly. It's not just kind of fit together in pieces so that we can benefit the orthopedic surgeon. So we have a lot of room to teach Americans and teach humans all across the world that musculoskeletal system is something you have to treat well, but that medication itself and surgery is not the pathway. Pathway is stability. Pathway is movement. Pathway is joint function. And getting back to simple things like not sitting all day long and squatting when you get to things will save your hips. understanding that you can't just lock and load your pelvis and lock your knees and stand in one place all day long and expect to feel, like your hips are free and perfect. So there's quite a bit of room to grow. I'd like to see it more of an integrated, non-disease model of looking at the musculoskeletal system.
Right. And in terms of education, there's, especially here in Australia, I can comment in Australia, and I'll get your input onto that. There's a movement where the universities are very influential, and you could argue rightly or wrongly, they're quite influenced by the evidence-based model. And speaking to some educators here in Australia, as they bring in certain aspects of that model, they are losing some of the traditional osteopathic philosophy, thought process, and application and technique that we would have been traditionally taught. What advice could you give to educators here in Australia, given your position over at MSU? What advice could you give to our educators here over the next 10, 20 years? How would you caution them to proceed?
I would caution them to proceed carefully, caution them in general. It's probably best to look at the physiologic axioms rather than the scientific evidence base.
Right.
Because the evidence base is really feeding the allopathic medical model. And it's doing so because what is evidence-based is really only studies that are paid for. Most of the money is coming through the NIH or pharmaceutical dollars. There's a means to an end with evidence-based.
Right.
And my recommendation is, that's my opinion, there's a means to an end. And that means to an end means that they're going to keep the human, the patient in the medical model and not allow them to work, not allow them to step out of that.
Yeah. And so, given what you just said now, I guess I'm going to ask you a little side question. Has the recent change in the United States approach with with obviously the incoming Secretary of Health, Robert Kennedy, and his approach to health, is that something that's been welcomed amongst either osteopathic physicians or medical practitioners on the whole?
Well,
Wherever you stand
depend
politically,
on their,
I'm not talking about
yeah,
that, but more so in terms of the approach in mindset. Like moving away from more pharmacological, I guess, influence.
I don't think the medical model is ready for that. I think they, in a way, they like it, but it's paid them well in America. So I don't think like an orthopedic surgeon is going to see much of a difference.
Yeah.
But I think that it still is in the realm of politics here in America.
Yeah.
I think people are really understanding the reality. I think that it's a good thing. Let's get in there. Let's make some. I think the changes that are going to be made are more in the area of nutrition. That's a great thing because I think people will end up healthier in the end. I think pharmaceutical companies are the ones that are going to be the most affected. I think they're going to fight because their lobbyists are the largest. I think physicians are going to just sit back and kind of do what they know to do. And physicians don't change their mind about anything here unless it's so if they see
unless it's paid for.
Unless it's painful, right? Unless it's paid for, yes.
Paid for, paid for.
Yeah. And painful. Or painful.
Or both.
So I think that it's, I don't think we know yet what's going to happen. I think that it's going to be tooth and nail by the pharmaceutical company to get us to move away from so many vaccines. I think for the pediatricians are going to fight to, to, to do that as well. I think the way that the physician payment model is set up, it's just meant to keep people really, really in poor health.
Mm. Yeah, that's a shame.
That's going to have to change, and it may be painful for the patient. Hopefully, the patient doesn't lose.
Yeah. Well, on that note, Lisa, I want to thank you for joining us tonight. There is so much that we could talk about. I'm hoping that you will do a round two with me sometime in the near future. There's a lot there, especially. I mean, we could focus on the textbook that you've authored and really do a deep dive into that. I think my listeners are mainly osteopaths here in Australia and New Zealand, hopefully, and there's a lot of students that are also listening as well. And I think they would really enjoy an episode maybe on that book to give us some insight as to what you want to achieve with it now that you've taken control of that. But I want to thank you for your time tonight here and this morning in Michigan. And people, if you want to catch Lisa, she'll be out here in February. Go on to Manual Medicine International and or speak to John Marshall, and he'll let you know where and whence Lisa will be out here in Australia, in Melbourne, in February. For everybody, thank you for joining us on this episode. Lisa, stay on the line with me, but for everybody else, thank you for joining me on another episode, and I'll catch you on the next one.